Good afternoon, everyone. My name is Ellen Meader, and I'm the Managing Director of the Center for Global Health Equity. Welcome to our webinar, Can Profit-Based Business Models Be Used to Improve Health Equity? Today, we're delighted to bring together several leading minds at the University of Michigan, working at the intersection of global health and business to talk about how the two fields can partner to advance a more equitable world. This panel discussion is part of a lead-up to the second annual commercialization competition, which is an exciting collaboration between our teams at the Center for Global Health Equity and the William Davidson Institute. This competition provides U of M innovators with extensive proposal review and mentorship as a vie for funding of $30,000. The competition is open to U of M faculty located on the Ann Arbor, Flint, and Dearborn campuses. Applications are due April 5th, and you can find a link to more information in the chat. Now I'd like to introduce our speakers for today. Dr. Joseph Kolars is the founding director of the Center for Global Health Equity at the University of Michigan. He serves as professor of medicine and health professions, education in the medical school. He's also professor of health management and policy in the School of Public Health and a consultant to NIH's Fogarty Center in their AFRI health initiatives in Africa. Additionally, Joe is an active advisor and contributor to numerous projects focused on human capacity building among members of the health workforce in low and middle income countries. Dr. Paul Clyde is the president of the William Davidson Institute at the University of Michigan, an organization who aims to unlock the power of business to provide lasting economic and social prosperity in low and middle income countries. He serves as a Tom Lantos Professor of Business Administration and the Moses and Maya Kaljian Collegiate Lecturer in Business Economics and Public Policy at the Ross School of Business. Paul's global health work focuses on strengthening the business practices of healthcare companies, including hospitals, clinics, and suppliers in low and middle income countries. Dr. Pascale Leroueil is the Vice President of the Healthcare Sector at the William Davidson Institute. Her research is focused on applying business practices to sustainably address human health needs in emerging markets. She has worked with both public and private health systems to increase their efficiency of care. Pascale also holds an adjunct appointment at the University of Michigan's Medical School, and before joining the William Davidson Institute, she worked in vaccine development at U of M's Medical School. So thank you to our panelists for being here today and for our audience joining us. And we'll go ahead and get started with our first question, and this is for you, Joe. From your extensive experience in global health, what are the most pressing health equity challenges you've observed in these regions?
Thank you, Ellen, and greetings, everyone. This is such a great topic for a webinar. First of all, when I think about somebody's health, I go back to basic definitions. What determines a person's health? Well, about 10% of it is health care, and then about 40% of it is actually their genetics, their own internal biology that they're born with. But 50% of a person's health is based on where they were born and the circumstances in which they live. Sometimes people call these the social determinants of health. But I think those are the issues that are in particular focus when we're thinking about health equity. Why is so much of your health based on the circumstances into which you were born? So when I think of global health equity, I think improving access to those who maybe aren't as privileged is one of the big determinants. So what do I mean by access? Access to information, access to resources, access to agency. How do you get somebody's voice really captured in the places of power where decisions are made? So I think of equity as trying to give a seat at the table to people who can be marginalized when the agendas are just established by the people who have a particular focus or want. So it's trying to lift all boats and trying to close that gap between the haves and have-nots. So that's how I would answer that question.
We appreciate your perspective and the experience that you bring with you. So Paul, the next question is for you. How can business models be adapted to address these health equity challenges without compromising on profitability?
I think when we think about without compromising on profitability, if a business is going to operate, it's going to have to be profitable. And so that's a necessary condition for it, because that's returned to the equity holders, just like wages are returned to the labor force. But businesses, I think, can play and are playing an incredibly important role in this, because they are filling gaps. I mean, businesses are designed they have the incentive to go out and look for opportunities where the market isn't being served right now. And so if we think about in healthcare in low and middle income countries, there are a lot of opportunities that are coming up as these countries continue to develop. And we see companies that are starting to take advantage of that. One of my favorite examples in terms of how they adapt, they do need to use different business models than you would in other environments. And sometimes that has to do with what we would call vertical integration, the degree to which they offer the full range of services, and going back all the way to raw materials and in different levels of the offering of the product or service. But one of the examples that I like is this company in Ethiopia that offers diagnostic services, and they are a licensed dealer for General Electric imaging equipment. But you can imagine in Ethiopia, there's not a huge demand for that equipment. And so what this owner did, Brook Fakado is his name, he bought his own equipment. And so he offers the imaging services as well. Now, most distributors don't do that in other countries, but he does there, and that offers them a revenue stream that allows them to continue functioning. And hospitals will refer patients to him. And then when the volume at the hospital becomes such that they want to buy their own imaging equipment, he is able to install and maintain and repair that equipment for them. So that business model is different from what you see in other places, but it's a perfect example of how it's addressing it. It's addressing it in somewhat subtle ways. I mean, it is providing imaging services to some who didn't have them before, but is also creating a new category of labor force, trained technicians who know how to install, repair, and maintain the equipment, which is the key feature for imaging equipment, because the equipment itself, while it's expensive, the biggest challenge is keeping it up and running. And by having this, and he's developed some very qualified technicians who are able to do that, and in doing so has created a market for labor that wasn't there before too. So it's addressing this health equity issue in a number of different ways, and businesses all over. We see examples of this all over in the countries that we work in, where they're filling gaps. They're filling places where consumers who haven't been served before are being served now, or consumers who weren't served in this way are being served in a better way or at a lower cost. And business is well equipped to do that. Now, it's not going to serve everyone, but it does fill a lot of those gaps out there.
That was a great example. And I think, Pascale, the next question, I think Paul touched upon this, but if you have other things to add to it. So, looking at the roles of business and public health sectors and how they're evolving in the pursuit of health equity in the developing countries.
Paul certainly took a lot of what I probably can add to this, but I'll attempt to do it anyway. So first, to the extent that the businesses are involved in the provision of healthcare, they are part of the public health sector within developing countries. And in many countries like India and Uganda, the private sector plays a large role in providing care, particularly to those groups of people that are wealthier. Having said that, I think governments are going to become increasingly focused on creating policies aimed at reducing health inequity because of pressure from citizens and to some extent pressure from the international community. This could come in the form of mandatory health insurance that covers certain services, or making it easier for the public sector to contract out to the private sector. So basically, the role of the government is increasing demand of services for all people within a country and reducing the barriers to entry for perhaps the private sector to engage in providing those services. On the business side, I think they're going to serve more and more people. For the vast majority of countries, I don't think the public sector is in a position to provide all the care that's needed, particularly if we go towards universal health care, which is what the WHO is trying to do. I think it's unlikely that for-profit businesses are going to be the primary providers of care for the very lowest, the poorest of the poor. So as Paul was talking about, they might be targeting different segments. But that doesn't mean those businesses aren't contributing towards increased health equity, because a patient seen, for example, in a for-profit hospital is a patient that doesn't have to be seen in a nonprofit hospital that the government is running. And so in that way, it's kind of taking the burden off of the public sector in some way. So it's not perfect, but it's contributing towards it. So I think both the government and for-profit businesses have a role in addressing health equity, increasing health equity, and I think it's going to happen. Whether we want, but I think it's going to happen just because of the way that demand is increasing for it within the countries. I think it's going to force it to happen.
And definitely policy, in governments and servicing the populations in the countries definitely play a role in this. Thank you. So, Joe, in your view, what are the key barriers to health equity in high poverty contexts?
Thank you. And I think largely the key barriers are resources and agency. And the resources can be knowledge, they can be money, and or just the opportunity to participate in solution making. And again, agency ties into voice. I want to tie this comment into some things that I'm hearing from Pascale and Paul, which I completely agree with. From a Center for Global Health Equity, some might argue that we should be taking our approaches almost in a socialist-like fashion, that we should be designing everything that should be to raise all boats, and to start with the neediest first. And of course, we do a lot of that. But I can't agree more strongly with the question that can profit-based business models be used to improve health equity? And I think the answer to that question is a loud yes, from my perspective. That, some might say, well, this is flawed. From a socialist viewpoint, you're only targeting the people who have money to pay. But I think we often start with change and innovation by looking at the people who have the money to pay. And that will create solution making that can then generalize and inform other approaches. But as Pascale was saying, if we're just dependent on models that are going to be funded by the public sector or by aid, it's not going to do it. And I think we really need to embrace the profit-making sector, entrepreneurism, having the people with the ability to grow and prosper and make money is also something that is going to largely address the social determinants of health. So I'm often involved with people who maybe would argue, well, we shouldn't be leaning so much on profit making. I don't think we should be leaning exclusively on profit making. But I think it has a crucial role in addressing health equity in low and middle income countries.
If I could just add to that, the point that Joe makes about the innovation, I think is key. And it sort of goes to the competition you mentioned at the beginning of this, Ellen. But there's a lot of work going on at universities around the world, including at ours, and this competition is aimed at that. But many of them are working with colleagues in the countries that we're working in. And those innovations are coming from experiences on the ground and the needs of the customers and thinking of different ways to provide services. And the market does a remarkable job of tapping into the entire population. Anyone can come up with an idea and can try to get it out there. And that's the power of it. If it's limited to just a couple of businesses, that's a problem, but it's not. I mean, anyone, as long as anyone is allowed to start a business and can take things to market, the market is an incredibly powerful force for coming up with solutions that no single individual could have come up with on their own.
If I could share an analogy of something I've wrestled with to see if this applies over in your arena. As you know, I'm a gastroenterologist is another one of the roles I play. And sometimes when I wear my healthcare provider hat in low and middle income countries, people will say, well, gosh, they don't need gastroenterology. They don't need people that do scopes and eye diagnostics. They need some really basic things: clean water, sanitation, healthy babies, vaccines, What are you doing distracting people with gastroenterology? And often some of the high-end technologies that are part of our discipline. So that's often an argument that's posed to me. And to be honest with you, I'm usually not a gastroenterologist when I'm in those settings. But one thing I wish people would appreciate is probably the best thing that can happen in low-income countries is to have their business people and their entrepreneurs to come back and take root and start contributing to their economy. You need people who can make the economy work. And people aren't going to move back to these countries or come into these settings if they don't see a healthcare provision that is going to take care of them if they get sick. So if I'm a wealthy businessman and I left that country and now I'm thinking of coming back to generate business and well-being for that low-income country, well, if I'm coming back and I'm going to get crushing chest pain, or I'm going to have maybe bleeding from my gastrointestinal tract, but there's no one around to take care of me because the focus has just been on public health measures, which are extremely important. That's not going to build the entrepreneurial class and the kind of businesses that that country needs to advance. So I don't know if you or Pascale run into that kind of thinking sometimes when you're trying to make business work in low-income settings.
Exactly right. And if I go back to the example I talked about before with Brooke, he didn't start his company to try to address global health equity. This was not his objective. That's not what he was thinking about. As a matter of fact, he is addressing that to some extent, but it's because he's trying to run his company, and in order to run his company, he has to employ people, he has to satisfy customers, and so I'll often hear in public health discussions about engaging different parts, but businesses have to engage them because if you can't get away, it's not like a box on a list that you're trying to make sure you did that. If you don't satisfy your customers, you're not selling anything. And that by itself plays a role. And if you look at India as an example, the healthcare there has been remarkable, the advances that you've seen there. And we've seen some significant innovations, at least on the business side in healthcare, come out of India. And they're doing things that aren't done in the United States and can't be done in the United States because of regulatory restrictions and whatnot. But they're figuring out how to do it based on the needs that they have there. And as you said, they have developed over time the trained workforce in different areas that make it the envy of institutions all over the world in some cases.
So kind of going a little bit further, Paul, from a business perspective, what incentives could encourage more private sector investment in global health initiatives?
That's a tricky one. That's a difficult question because when you're thinking about incentives for businesses, you've got to be careful because you don't want to create distortions. You run the risk of encouraging activity that the consumers, in fact, don't want. So I would almost flip that around and say, take away the disincentives. And the disincentives are often regulatory. It's governments make it difficult to start the business, or governments make it difficult to import parts for your equipment or parts for different things that you're doing. Businesses, those are costs to businesses, and those increase the cost and decrease their ability to serve customers. So if you can take away those restrictions, that would be beneficial. And the other thing I'd mention along those lines is stability. Businesses, it's very difficult to operate in a volatile economy or a volatile political environment. If you don't have stability, that's another cost to operating a business. So when I think about incentives, I think about, doing what you can to, especially from a government perspective, to look and see how do we take away the impediments to starting a business or to running your business and make it so that they're not bearing costs that are unnecessary for operating their business. And how do we create stability in the environment? I think Pascale may have something to add to that because I know she interacts a lot on this side, and I hear war stories from her all the time.
No, I mean, I echo with what you said. So if I think about the two steps in the business, there's the startup process and then there's the ongoing process. And to what Paul was saying, there are lots and lots of regulations in place that make it really difficult to start up a business. It takes a long time. It takes a lot of money. It takes a lot of connections within governments. And to the extent that you can decrease those barriers, you got more companies in the market. And then keeping them in the market is the next step, is how do you reduce the cost to them staying in the market? How do you make it so it's easy for them to get cash? How do you make it so that there are banks available to loan if they need to make improvements on their company? How do you make it so it's easy for them to get the equipment that they need? How do you make it easy for them to get trained people that they need to work their business? It's all about reducing the barriers. I think if you reduce the barriers enough, companies are going to find a way to do what's right. You just have to make it so it's relatively easy for them. The one thing I'll say that it would be helpful if governments were doing that is an action is making data more visible. I think one of the challenges that I see within the space that I work in the countries that I work in, is that it's really hard to know what's actually going on and how stuff works. There's what's written in the documents and what's available on websites and databases and in policy notes, and then there's the reality. And if you don't know that those are actually not at all the same, it makes it really hard if you're a business to try to start a company. And so making it so the information that is available is right, and making it so it's relatively easy to get, I think would reduce the barriers reduce a lot of the barriers for companies to start.
So Joe talked a little bit about agency earlier. So Pascale, how important is local community engagement in developing sustainable health equity solutions, and how can businesses help facilitate this?
So the answer is very important. So understanding the local community where you want to deploy a particular solution is really just understanding the customer, which is business 101. So one thing, though, that's important to think about within the healthcare space is that there's usually three customers. It's not just one customer. And this is true whether we're talking about the US or Nigeria. And the three customers are the buyer, so the person who's actually going to spend money, the person who's going to cut the check for you. The second is the user, so the person who's going to deploy whatever technology is. It could be the nurse, it could be a midwife, it could be a physician. And the third is the beneficiary. So this is usually the patient. So in order for a product or service to work within a community, all three of those people have to be happy. If they're not happy, they're not going to buy the service. The service is not going to work. Your business is not going to survive. And I think the vast majority of for-profit organizations understand this. They know that there are those three customers that exist, and they know they have to satisfy those three customers. The challenges I think they face, particularly when you're talking about companies who are based in, say, the US or the EU, is that they don't know who those particular people are within a given community. So, for example, if I'm Brooke and I've got a big piece of equipment and I'm trying to do something with the national government, I may think that I'm supposed to go talk to the procurement officer at the hospital to buy my piece of equipment, when in fact, all of this has to go through the national central level folks. And so that lack of information makes it really difficult can make it really difficult for a company if they're interested in selling a particular product or business, or selling a particular product. So in summary, so if a business wants to enter a particular market or a particular community, they have to understand that particular market and that particular community. You can't get around it. You're not going to be able to make money if you don't. And they can do it a couple of ways. They can spend a lot of time in that community. They can, talk to their customers, talk to their patients, talk to the buyers, talk to the doctors who are going to use these services. They could do it themselves, or they can partner with someone who has those connections, who understands that community. But one way or the other, they have to understand who their customers are, and that is the community.
I think she's exactly right, and that's incredibly important, whether they're multinational companies or companies that are even from that country, but maybe not familiar with that region. Distribution is one of the biggest challenges any company faces. And you can produce your product wherever you want in the world, but if you're going to distribute it effectively, if you're going to market it effectively, you've got to know the local population. The best way to do that is to either hire someone locally or work with a local organization in a partnership.
Pascale, Paul, I wonder if I could just have a point of clarification with you. I know this webinar is on a profit-based business models. One term that I often hear thrown around is social entrepreneurism. How does that term, is that a useful term for you over in the business school? Or how do you use and think about that term or that concept as it relates to what we're talking about here? Are we talking about social entrepreneurism, or is that something else?
Go ahead, Paul.
Do you want to start?
Sure, I'll take a stab at it. I don't know what the definition of the term is. I'll be very clear on that. But when I hear the term, I think of someone who's willing to take a hit to their profit in exchange for something else. So that might be in exchange for serving a group of people that may not otherwise be served. It might be employing people who may not have the exact training we want. It's basically taking some hit to your profit in order to do that, in order to run your business. And I don't think we're necessarily talking about social entrepreneurship in this case. There are businesses that can operate in these markets that can prioritize profit and still do good in those markets. If they're, for example, targeting the very high income folks that have the ability and willingness to pay for those services. They are a for-profit company, plain and simple. That is what they are. Having said that, I can imagine nonprofit organizations, not nonprofit organizations, but there are other organizations that are maybe targeting that lower end that they can break even, but because they can break even, but they may not be able to break even because they choose to serve lower and middle income folks instead of the top high income. So that I might call those more social entrepreneurs. But honestly, I don't know what the definition is. And yeah, I'll leave it to Paul to fill in.
So yeah, I mean, the definition means different things in different contexts. And I generally would accept Pascale's version of it, that somehow you're accepting lower profits in one way or another, or some resources accepting a lower return than they normally would. The term is used at the business school extensively. It's always sort of bothered me because the implication is that other businesses aren't offering social services, which to me is completely wrong. Every business that's out there has to satisfy customers. And in doing so is creating what we in economics would call consumer surplus, which is a social good. It's socially valuable and has to employ people and buy resources and work with suppliers, which also benefits society. And we would call that producer surplus. So I think of every company, when people say social enterprise, in some sense, I would think every company is a social enterprise because they're having some impact on society in providing the good or service that they're providing. So when I'm talking about this, the examples that I'm thinking of and that I'm talking about are not different from any other profit maximizing company. They're just figuring out ways to do it. They're by serving markets that haven't been served before, and in that way are providing value to society. So I think the term therefore loses some of its meaning, because if every company is a social enterprise, then how are we separating them? Unless we're talking about them accepting lower profits, which, as Pascale said, that's fine if they want to do that. It's not something that's going to grow because nobody else, and this is empirically true. We observe that other companies don't enter that. There's no incentive to enter that. And it's difficult for that company to grow because you use the returns you get to finance your future growth in part. And if those returns aren't coming in, you can't grow. And so it's sort of, if we're talking about it as the entities that are accepting a lower return, either on equity or labor or one of their other inputs, then it has a natural barrier to growth that makes it somewhat less exciting in terms of the impact it's going to have on the market. And if we're talking about it as firms that do have a social impact, then in my mind, that encompasses all the companies that are out there because they're all having a social impact.
Very helpful. Thank you.
Thank you. So, you all have talked a little bit about how government agencies can help create more conducive environment for businesses. But Joe, how do you think the public health sector can create a more conducive environment for businesses to invest in health equity?
I think one place is in recognizing the value proposition of people who are driven and can see a way forward with some profit making that's going to return hopefully exceptional value to the individuals, to the customers. Sometimes I regret in some of the public health discussions that I'm in that profit making can be seen as dirty, or that something that is undermining a primary value, a social good, that profit making is just inconsistent with that. So I think one of the places to answer your question, Ellen, is I think the public health discussions can have a more enlightened view to the possibilities. Maybe to take an example, let's take Paul's example that he started with the business person in Ethiopia. I think what people sometimes in my colleagues can quickly go to is to say, well, is it less good, if not wrong, if this is Joe Kolars, a citizen of the United States, somebody who lives in Ann Arbor, who's figured out some profit making that's going to extract money from Ethiopia and bring that into Michigan, and versus somebody who's been empowered and enabled in Ethiopia, who is actually generating profits there and not doing a big profit transfer. But I know sometimes my public health discussions, they're saying, so you're going to make money in a place that is low income, and you're going to do further wealth transfer from areas that are impoverished into the land of plenty here. So I think that's often a reflex that people see when they're thinking about profit taking. So I think we can be having better discussions and more enlightened possibilities in discourse with the public health sector.
We do have some questions from the audience, so I'd like to move to those questions. We have a few more minutes before we are getting to the end of our time here. So one of the questions is, should there be more emphasis when thinking of these issues on separating the financing versus delivery of care? And then they have another question. Finance the care through social means, thus allowing the beneficiaries to be targeted as desired, but then allow for profits, presumably more efficient, to deliver that care. And as for the profit gains experience in that sector segment, hope that they'll expand their presence to segments that may pay their own way. So I can repeat some of that if you need to.
So I mean, I'll take a stab at the first question. My answer is yes. I think that's how we should start thinking about it. That it doesn't have to be the same organization that's financing the care that's delivering the care, and that happens in lots of different countries. That's exactly how healthcare works. Take Switzerland; it's financed by the public. It's financed by the public sector, but it's provided by the private sector. The care is provided by the private sector. So it can be one versus the other. I think moving more towards financing by the public sector and provide and leveraging what the private sector can do in the delivery of care, as the questioner noted, to make it more efficient is a good thing. It's a great thing. And I'll say that I try to use that. I try to bring that up many, many times during discussions I have with the global donors, of making sure that we are separating this provision versus the financing, because I think as Joe was talking about, there is this immediate, we don't like this within the public sector when we're talking about partnering with private hospitals that might want to profit if they provide particular services, that making them recognize, no, there's value in what they're able to do. They may be able to do it more efficiently than the public sector can do. But yes, in summary, I think it's, yes, the absolute right way to think about it.
Yeah, I would just add to that. I agree in general. The one caveat I have is you have to be careful when you're the financier, because so in the private sector, the financiers are, whether venture capitalists or private equity or trading in stock or equity or whatever, they have an incentive to monitor and what's going on and to invest in the things that they think are going to be in demand. And so they have the incentive to look for what is it that consumers want and what is it that they value. When you have the financing come from government, you run the risk that the government isn't looking at that and maybe investing in and thereby encouraging or forcing something that the consumers don't want. And it's a little bit of a challenge, because there is this, it's true that the private sector is not going to provide healthcare to everyone. And so you have to figure out some other way to get there, whether that is through public financing or donors or whatever. But then you have to be careful about that, because not only are you not sure what the consumers are wanting, but you also run the risk of crowding out. There might be a private entity that could operate and would be operating, but for this publicly funded entity that's coming in or not-for-profit that comes in and sort of forces them out of the market or makes it more difficult for them to operate profitably. So it becomes a difficult question in some cases, but yeah, I agree with Pascale that you can definitely separate the two, and we see that in a variety of different markets.
Paul or Pascale, I'd appreciate your thoughts on an example I'd like to offer. And with some apologies to the audience, again, I'm a physician. I think physicians are overly dominant sometimes in the discussions because health is so much more dependent on other things than physicians. So with apologies, but I'll offer a physician example. As I think you know, I work quite a bit with universities in low and middle income countries. And I work a lot in many of these countries. It's the university hospitals that are the dominant hospitals, that they're seen as the leading edge of healthcare that are trying to provide care to the population. I'm really hard in almost all cases when I'm working with physicians who are working there. They work there, and I think they are largely in the public sector. They're working for the universities, supported by ministries of health, and they're setting the standard. And they're training the next generation. But all of them have a private practice on the side. They can't support themselves just with that public sector support. Sure, they're in the leading hospitals, they're teaching and growing the next generation, but then they have to have a private practice to provide their income so that they can feed their family, they can send their kids to school. And this isn't the dominant portion of their work, but they wouldn't exist without it. So sometimes when people of my ilk, we're not allowed to do this here at the University of Michigan. I'm a physician, a clinician that just is beholden to the University of Michigan. I can't go out and have a practice on the side to supplement my income. So people, they kind of hide this aspect of their practice, their performance, because it doesn't necessarily look flattering, but that's what they need to do. And then some of the time, these side practices are becoming organized into private hospital, private institutions. And of course, these are catering to the people who can pay for those services. And maybe the clinic that they're walking into is maybe more pleasant, more amenities than if they saw that same physician in the public sector that morning. So this dynamic, I think, is already very well in place and is absolutely necessary if the public sector is going to have providers and clinicians that are working for people who can't pay. But so that's something I observed quite a bit. Any thoughts or reflections on that and how that ties into your point of view?
I'll just give a quick reaction and then Pascale can chime in. I observe it as well. And in some cases, the public hospital itself actually sets up a facility because they know the doctors have to do that. So they're sort of almost encouraging it, and it's their way of compensating them. So yeah, I understand the conflict and that you wouldn't be allowed to do it. But I also understand that, that's a good example of, we're not in a position to judge that because you're absolutely right. They couldn't offer their services if they weren't doing that at the same time. But I think it's also important to note they're not doing it behind the backs of the hospital they're working for, in many cases at least. In fact, that hospital is often encouraging it.
So we appreciate the wisdom that you've shared with us today, Joe, Pascale, and Paul. And thank you to our audience members for joining us. And as we wrap up the webinar, we just want to remind you about the exciting opportunity through the Global Health Commercialization Competition. Faculty members from all three of our campuses are eligible to apply for the funding of $30,000. Those proposals are due April 5th, and you can find more information on the center's website. Again, thank you to our panelists and our audience, and we hope you have a great rest of your day.